Hello, everyone, and welcome to the Parkinson's Foundation Wellness Wednesday. My name is Sarah Maldonado, Community Program Manager for the Parkinson's Foundation in the Southwest Chapter. Today, we are pleased to bring you a talk about DBS. Before we begin, we want to welcome those of you who are joining us for the first time and take a moment to share the mission of the Parkinson's Foundation. Every day and in everything we do, we are working to make life better for people with Parkinson's. To achieve our mission, we pursue three goals: improve care for everyone with Parkinson's, advance research towards a cure, and empower and educate our global community. Today's program is a great example of one of the things that we're doing to help us meet these goals. Today's program is brought to you by Abbott, whose generosity has made this programming possible. Thank you, Abbott, for your support. We have started a new initiative meant to capture the community's perspective on various topics in Parkinson's disease, like mental health, telehealth, and cannabis. By signing up for this initiative, we will email you up to 4 times a year requesting that you complete a 10 to 20-minute survey. We will always report findings back to the community and encourage you to visit the link on your screen for more details. I'm now pleased to introduce today's speakers, Dr. Isabel Alfradique and Candace Mueller. Dr. Alfradique-Dunham is a board-certified neurologist with fellowship training in movement disorders. She specializes in Parkinson's disease and has additional training in genetics and neurodegenerative diseases. She graduated from Universidade Federal Fluminense in Brazil and completed neurology residencies in Brazil and Texas. Dr. Alfradique completed a movement disorders fellowship at Baylor College of Medicine. She is currently an assistant professor at Washington University in St. Louis in the movement disorders section. She takes care of people with Parkinson's disease, including evaluating candidates for deep brain stimulation, working with the neurosurgeons during the DBS surgery, and in follow-up program. Candace was diagnosed with Parkinson's in spring of 2012 at 59. She retired at 65 and started her new chapter with adding more exercise to her medical plan along with Cinemet. Through a Parkinson's dance class, water aerobics, a boxing circuit class, yoga, and walking her lab Layla, she became acquainted with a new group of friends living with Parkinson's in Springfield, Illinois. She established a resource guide with Parkinson's for the greater Springfield area, pdbuzz.com. She convenes a weekly group of Springfield area people with Parkinson's now via Zoom. Her DBS surgery was in March of 2020. Her career in government relations spanned advocacy for adoption and foster care reform, public education funding, and higher education starting in Washington, D.C., then Trenton, New Jersey, and Springfield, Illinois. Candace and her husband remain pensioners in Springfield while their adult children live in New York City and Chicago. Meeting people living with Parkinson's from around the globe has been an added plus to living with Parkinson's. Thank you again, Candace and Dr. Alfradique. I will turn it over to you now.
Thank you very much, Sarah. And Dr. Alfradique, it's so good to see you.
I know, it's good to see you too.
August is our 2-year anniversary. Back and found our first appointment, and we met August of 2019.
That's true.
So we were 3-dimensional then. We're only 1-dimensional today, but it's so good to see you. So I would like you to start off with like what you did with me in August of 2019 and explain deep brain stimulation for those attending today's session.
Yeah, so thank you for inviting me to come over. It's a pleasure to be here. So deep brain stimulation, which I'm going to refer as DBS, is a treatment modality for people who have Parkinson's disease. The goal of the treatment is basically to help to improve some of the symptoms related to the disease, that when they reach a point that the medications are not being enough to improve those symptoms. And those symptoms tend to be tremor, changes in mobility, stiffness, the slowness of movements. Those are the symptoms that tend to get better. So what the DBS is, it's a device that works as a pacemaker in the brain. So it is a lead that we insert in certain parts of the brain, actually either 2 areas, globus pallidus or subthalamic nucleus, and we start to pace the brain cells in those areas. And it sounds like what we've learned through the last few decades is that once we do that pacing, that helps. It's like to improve those symptoms related to the Parkinson's. It is a 3 piece device. So you have the lead that goes into the brain. You have the battery that stays on your chest, and that's what generates the electricity to allow us to deliver that stimulation. And there is a third piece that connects the battery to the lead, which is what we call an extension. So I think the idea of the pacemaker is the best way to think about it, because in practice, that's what we end up doing. We modulate the amount of electricity that we give it to those areas of the brain, and that has helped us to get more symptom control and improve quality of life.
Thank you. Who is a good candidate for this surgery?
That's a very good question. So there are 3 general profiles of candidates for deep brain stimulation. One profile is of those folks that have been on levodopa. Levodopa works well for them, but the duration of that benefit is kind of getting shorter. So initially, when you start on levodopa, the medication may last throughout the day once you take it 3 times a day. And then over the years, that duration can get shorter and shorter. And then maybe people find themselves taking the medication every 2 hours, every 3 hours. So in those cases, the stimulation can help to ease that benefit of the levodopa and make it a more sustained benefit. The second group of people that benefit from deep brain stimulation is the group that have a lot of dyskinesias. So dyskinesias are a series of involuntary movements that tend to happen when levodopa is working. Most commonly what we see are like some head bobbing, some swaying of the trunk, but it can also happen in the arms and legs. When the dyskinesia happens, we tend to try to cut down the dose of the levodopa, but that is not a possibility for a lot of people, because then they feel worse with the stiffness and slow movements. So then once we try a medication called amantadine and the dyskinesias do not get better, we're kind of stuck because we cannot decrease the levodopa. And at the same time, we don't have a good option to treat the dyskinesias. So in those folks, the DBS serves us to have a sustained benefit of the levodopa without as much dyskinesias. And the third group, which is not the majority, it's a group of people who take levodopa. Levodopa helps them, but that tremor doesn't get better. And so for those folks, the DBS can provide an extra benefit, which would be additional tremor control. Those are general groups, but what I say to people is that if you are in a situation that you feel that the symptoms of the Parkinson's are not well controlled, I always think it's worthwhile to decide to see a movement disorders specialist that works with DBS to see if DBS can add anything to the case of that person. So it's, in the end, it's a very personalized approach. Even though we have those 3 groups, maybe DBS can contribute in some other ways, but those are the general groups that we tend to think about.
Thank you.
And Candace, what made you consider DBS?
Well, you actually described it perfectly, Doctor, in the very beginning when you talked about the on and off periods. Carbidopa-levodopa was my friend. There was no question about it. But then just what you described happened from a day long to maybe 4 hours or 5 hours to maybe 3 hours, and then even down to 2 hours. The on and off periods were happening. And I also developed dyskinesia and had a weight loss related to that. Mine was like a moving, people used to call me dancing. I would dance around sometimes. And so, although friends had sent me articles early on, as soon as they heard about my diagnosis for DBS, and I looked at them, I said, well, that's not for me. Certainly, the progression of the on and off periods made me think about my quality of life and that DBS might be the answer. I watched a wonderful webinar on Davis Finney with 4 people who had DBS done. After we had our appointment in August of 2019, the center sent me a wonderful document called Parkinson's Disease, Deep Brain Stimulation, a Practical Guide for Parents and Families, written by Dr. Michael Oken, who many of us should surely know his name. And I guess he's the medical director for the Parkinson Foundation, and Pam Zielman. And that was very informative. And as luck would have it, well, as fortune would have it, in my friends group, another gentleman was exploring having DBS, so we could compare notes too. So not realizing that it was not experimental anymore, that it was really low risk, that it's reversible, all those things just seemed to come into place. And I said to my neurologist that I was meeting here in Springfield, I think I want DBS. And he immediately sent me to the Washington University Center, and I met you. Can you describe the evaluation process that you use when somebody asks about DBS?
Yes, absolutely. So what I'm going to describe, excuse me, is actually the evaluation that we do. Oh, I'm sorry, that we do in our clinic. But so other centers may have a different routine to evaluate people for deep brain stimulation. So you have to keep in mind that this is our experience, but things can be a little bit different in other places. So usually when a neurologist, either within our group or outside our group, thinks someone may be a DBS candidate for whatever reason, that person comes and see one of the DBS doctors, and I'm one of them in the clinic. And we spend 1.5 hours, not only to understand what are the symptoms that are happening that have been difficult to control, and also to determine whether those symptoms could improve once the person has, if the person gets deep brain stimulation. So that is and then in that visit, I show normally people the device. So I have it's actually the device itself that we use, and then they are able to see the different parts and have a better understanding what the DBS does. That visit is really important because it helps us not only to refine whether the person's a DBS candidate or not, but also it's an opportunity for people to answer very common questions about deep brain stimulation. So things like, can DBS cure Parkinson's disease and the accessories? No. Is DBS experimental? That's a very common question that you had too. And the reality is not. DBS has been around since the late 1990s. So it's been around for quite some time, and we know about it, what it does for quite some time. Can DBS decrease the amount of medicines that I take? And the answer is maybe. So some people do notice some improvement in the amount of medicines that they have, but I never promise that will happen because some people do need to keep on their medicine. So we kind of address all those questions. And then after that evaluation, if I think someone is a potential DBS candidate, then you have 3 more visits. One of the visits is a visit with a neuropsychologist. And the importance of that visit is that we do not do deep brain stimulation in people who have dementia. We know that we suspect the outcomes for those can be worse, and there is some evidence that DBS can make probably cognition worse. So we do have this meeting where the person meets a neuropsychologist and has a couple of hours of neuropsychological testing to assess memory, attention, and some other features. Very commonly, people have some changes in the neuropsychological testing, but most of the times those changes are not enough for us to hold off on doing the surgery. Another visit that we do is what we call an on-off evaluation. This visit is basically a visit that people come to the clinic. And right now, what we are doing, you were in the hospital. Now, since COVID, we've transitioned to do that in the clinic, and it has worked really well. So the person comes to the clinic after spending around 12 hours without taking any dose of levodopa or any medication for the Parkinson's. They come into the clinic in what we call an off state, meaning their symptoms of the Parkinson's are there without any treatment. And then we examine that person with a video camera. We give some scores depending on how the exam looks like. And then we give levodopa in that after we exam. And then we wait a little bit for the levodopa to kick in and see if the medication changes, what are the parameters in the exam that have changed. So that visit is very important because it gives us a good idea of what exactly are the benefits of the medication. And that helps us to estimate what are the things that that the stimulation could potentially help people. And a third visit that happens is a visit with a neurosurgeon. So that visit is important not only for you to meet your surgeon, but also for the neurosurgeon to come up with whether there are any other medical issues that can increase the risk of having the surgery. So if you are taking blood thinners, if you have any other medical problems that are not as well controlled. So that is the visit that we use to kind of have a plan for the surgery, and if the surgery will be a safe surgery. So that's, as you can see, takes some time for us to finish all that evaluation and say, yes, absolutely, I think DBS is the way to go. And there are multiple layers that we in our center, we only do DBS surgery on people that we are sure that will benefit from it. So that's why we are very selective, and we want people to go through all of that work and get benefit in the end. And then what was your experience with this evaluation process? Because it's a lot of work.
Oh, I didn't think so. What I came out of it with was that I had a competent, efficient medical team surrounding the DBS surgery at Washington U. It's also was nice to realize that I wasn't demented. I actually take place in another study for Washington University that is dealing with that. So I had taken the test a few more times. So, but it still is always good to feel like you still have your brain. And this was my first experience with being off the medicine for 12 hours. And it really is interesting. And so I got to be on the video, as you said. And then within an hour and a half after taking the pill, magically, the video was just so different. So I figured I probably had succeeded there and being a good candidate. In fact, the carbidopa does work for me. And then, of course, it was very good to meet my surgeon, who was very confident and shared confidence that he had done this many times. And I went away feeling like I was chosen, the right one had chosen me to do the surgery on my brain. Probably the worst answer he had for me, which I found throughout the whole thing, was, tell me about shaving my head. And he kind of dismissed it, as a guy would, I guess. He said, yes, we shave your head, and no, I don't do a very good job of it. That was my vanity question throughout the whole process. And it turns out, moving ahead.
You look really cute with short hair. You looked really cute with short hair.
Well, it turned out all right. And what was fun about it, again, is that my son, who had hair down to here, joined me in a unity campaign, and he shaved his head too. So his hair is now about here. I keep getting mine trimmed, of course, but we're competing now on letting our hair grow back out. So again, it was a good day and a half. I can understand why you wouldn't need to use the hospital, since I've started the battery adjustments. I go without carbidopa for 12 hours and come into the clinic holding on to my husband's hand, although not so much anymore, and then leaving, walking freely. So you probably, the hospital, the clinic makes sense in that regard. So that was done in November. I had an appointment with you in August, and in November, I had the day and a half of evaluation. And then by the end of November, I knew that I could have the surgery, and we scheduled it for March of 2020. And so it was just a waiting process, one where I was really glad I had my friend here in town to compare notes with. He had his surgery in December, so he went ahead of me. And all in all, I just felt confident going into the procedure.
Yeah, and you said something that is important. Usually when you see the surgeon, that's something that I encourage people to ask them, is about the experience of the surgeon, how many surgeons the person, that surgeon has done, and what kind of complications they have had. So that it gives you a good sense of how long this surgeon has been doing this and how good he or she is.
So now we come to the day of the surgery. Would you like to describe that to us?
Yeah, yeah, absolutely. So the surgery day, again, it's also what I'm going to describe is the experience of our university, but you may have some changes of how the surgery happens. And I'm going to touch on a couple of them. So on the day of the surgery, the person also comes off the medication for around 12 hours. And then after they go through all the paperwork, you go to the operating room, and then that's when they shave your head and they put 4 studs. That would be the official name is fiducials, but let's call it studs because there are really some studs that they put around the head. There are 4, and they are placed with local anesthetic, and then so they should not hurt. And after the studs are placed, people have a brain MRI in the operating room. Once the brain MRI is done, while the staff is preparing the person who's about to get surgery, me and the neurosurgeon, we are calculating based on the MRI and the position of those studs, what is the angle that we are going to insert the DBS lead in the head and how deep it should go. So the MRI is kind of our roadmap to get to the spot that we want to be. So once that is calculated, those we start to finish prepping the person. So when I'm in the OR, I evaluate the person that is in there to kind of have an idea of how the exam looks like. And the surgeon's going to place a series of frames around the head. Those frames they are anchored in those studs, and they have a series of rulers that help us to determine in 3 dimensions what is the angle that we need to insert the lead. So once that is done, they're cleaning the head, and then they put a series of like drapes around you so that they isolate the area that is sterile. Then the surgery begins. The surgeon puts a local anesthetic in the skin of the head and the scalp, and then make a small incision. And after that incision is done, they flip the part of the skin back, and then they drill a small hole that is around 3 millimeters. It's like about the size of a pen tip. And then once that space is drilled in the skull, then we insert a tinier catheter, not the DBS lead, but a different catheter that we call microelectrode. So that tiny catheter is there to capture the activity of the brain cells. And so those areas of the brain that we drop the DBS lead actually have a very characteristic electrical activity. And this is a way that we do to double check that we are in the right place. So we put that catheter in, and if we find the typical electric activity of the brain, the person who is laying down there hears something like shh, kind of like one of those old TV sounds. That's what you hear. It doesn't hurt to do that. And so once we insert that and we confirm that we are in the right place, that the MRI really brought us to the right place, then we remove that tiny catheter, and that's when we insert the DBS lead in the brain. Once that the DBS is in there, then the role of the neurologist who's in the room is to turn on the stimulation in the DBS lead to confirm that we have benefits when we are turning it on. Benefits would be the speed of movements of the hands will be better, no tremor if the person has tremor, or the muscle stiffness gets better too. So some of those same tests that we do in the clinic, that's what we do in the operating room. So we also want to see some side effects that come from the electricity kind of expanding to areas surrounding the target. And that is important to confirm also that we are in the right place. And the side effects could be numbness, tingling, and depending on the severity of the side effects, we may decide to reposition the lead. But most of the times we end up like hitting the place in the first shot. Once that is done, then the neurosurgeon makes sure that that lead will not move. So he anchors that lead in the skull. And then after that is anchored, we recheck to make sure that we get the same benefits. Once that is done, Then we do the same process on the other side. So the surgeon closes up after all is done. Usually people arrive very early in the morning, like I think around 5 a.m. or so. And then the surgery ends up finishing, if it goes everything all right, around 12. After the surgery is done, all those devices that were around your head are removed. The person gets the medication and the levodopa and the other medicines they typically take. And they get a CAT scan, a CT of the head to make sure that we did a good job putting the DBS lead on the place and the person didn't have any problems with the lead, any bleeding, any other issues. The person stays overnight in the hospital, and then by next day, if everything is fine, they go home. Then in about 2 weeks later, they come back to do what we call a day surgery, meaning they are not going to stay in the hospital overnight. They're going to come in, we're going to put the person to sleep, and then that is the phase that they're going to connect the rest of the system. So they're going to connect the extension to the battery in the chest. So basically you get in, they give you anesthetic, the surgeon does all of that, and then once you wake up, you're eating, walking, going to the bathroom, then you're good to go home. Around 4 weeks from the first surgery, and 2 weeks from the second surgery, you come to see us in the clinic. And that's when we turn on the stimulator again. This is enough time to wait for the brain to heal. And that's when we're going to start the process of giving the stimulation and slowly bump up over the next few months. It's important that there are some centers that have do this process in different ways. So there are some centers that do not do the recording that I mentioned. They do all the surgery based on the MRI. There is no evidence so far that's showing that one method is better than the other. So what I tell people is just go with the person is used to do, because most likely it will go well. There are some instances that people cannot get the surgery while awake, and we evaluate based on the case-by-case basis to see whether we could do the surgery as sleep. But that's not the routine in our center, though it can be the routine in other places. And Candace, how did you feel on the day of the surgery? Because it can be quite tiring. How was it?
Well, I think that there's kind of two ways that I like to describe it in lay person's terms. And one is probably not uncommon for any surgery. It's kind of like getting in line for a roller coaster ride. So when you're in the bed and you know that you're going to get in this chair, or the roller coaster, or you're going to get in the operating room, and then when they put the belt on you for a roller coaster ride and they put those nails in your head to put your head down so it can't move, you're there and you can't go anywhere, and the roller coaster ride starts. The other thing is that ultimately, it's, as a female, as a mother, it's kind of like labor and delivery stories. When it's all over, it's, it's really, it becomes a secret. I mean, in the sense of you don't really remember all of the scariness that you thought you might have. But in terms of pain, there really is no pain. I mean, when the doctor said he was giving me the anesthetic to numb the brain, and that would be the worst, he was right. Now, in terms of the restrictions, like being in a dentist chair or a roller coaster and not being able to get out, you've got to use your mind and those around you to keep your thinking about other things. And again, the nurses and the team were wonderful. I teased him a little bit right before they really got started. I asked the nurses if I was going to be laying there this long, whether they might microblade my eyebrows. And they had a good laugh, which I was glad they did. But other than that, it was just a very interesting experience. Now, I had both leads put in the same surgery, and it was wonderful when the doctor's holding my hand and checking whether it was reacting or not, said, we've hit the spot, and they got all excited. So of course that was very positive too. And even if it was a fake excitement, it was an important one. I don't think it was fake, because it certainly has worked in that regard. So
Yeah.
when I came out of it, I had a headache. My daughter went and got a big latte, and truly, after I drank that caffeine, I had no more pain the whole rest of the recovery, truly. So it really is not as scary as you think it could be.
Yeah, you mentioned the eyebrows. That reminded me, one person was telling me that what I really want right now is a chicken fillet, and everybody was so starving in the room. And we're like, why did you tell us that? But yeah, sometimes people like crack some jokes during the surgery, but I agree. It's like, I think by the end of the surgery, some people, because they've been off the medication so long, it can become uncomfortable. And then it's our team, like, do we need to reposition the arm, or do we need to massage somewhere to make people
Right.
more comfortable?
Right.
And now that you've had the surgery, how long did it take for you to heal, and how long until you saw like any results?
Well, the healing of the stitches and all went fine, and thankfully no infections or anything occurred. And I have bumps in my head that you can't see, and then of course I've got 2 scars here. But I was told to be patient, and you need to be patient. I certainly had a couple wonderful experiences right after the surgery, called the honeymoon experience, where in fact I just felt totally normal. And you wanted that to keep on forever, but it doesn't. And you were told it's not when you read things about it, but it did happen, and it's a wonderful feeling. But since I was in Springfield, it's an hour-and-a-half interstate ride to St. Louis for the I always forget what to call them, but the battery calculations. Those mornings were really interesting because I was off my medicine. And it really made you realize how dependent and how grateful I am for carbidopa-levodopa. It still works for me. It really works. And my main symptom is stiffness. So to just realize how stiff you can be, and then once you take the pill after the programming is done, and you're ready to go home, you're just grateful very much for that. And I've been very grateful for this first world surgery made available to us. Being a Medicare patient, we in the United States are also very blessed. And when I think about third world countries not even having carbidopa-levodopa, I do feel a little guilty. But my quality of life is indeed better. And I just say to people, you can do this. You got this. If you have it is not a cure, obviously, but it is a quality of life improvement. And
Candace, once you had the surgery, can you tell people like how is the routine after you have the surgery with the initial programming and later on? How long does it take for you to start to notice benefit? Because you mentioned the honeymoon period, which is right after the surgery, because there was so much inflammation in that area. People may feel better, but that goes away. But then when the programming starts, what was your routine at that point, and how long did it take for it to really start to work for you?
I still took carbidopa-levodopa. I tried to extend it out a little bit, and I continue to try to do that. But it was a long 6 months. Now you have to also realize my surgery was March 4th and March 20th, 2020. And that was just the day, honestly, the March 13th surgery with the batteries was kind of the day that schools were closing and the country closed down. So it took me a while to get back to St. Louis. So I had to be patient that way too, before they even revved up the batteries. But it was a long 6 months. I don't mean that in a long, dreary period, but patience, and just keep going at it and keep taking your carbidopa-levodopa, keep exercising, keep moving. I just got back into the same routine. And now I'm really excited. I have an Abbott system, and I'm going to do the Neurosphere virtual clinic in November with my nurse practitioner. So I'm going to use my phone and my magnets at home, and I'm going to learn how to program it myself. So does that answer your question?
Yeah, it does. I think it's important for people to have this understanding that the surgery is just the beginning. Then after that, we have this first 6 months of programming. And even when we turn on the simulation, as you mentioned, you do not have like that robust benefit. So it's not that you're already doing well. You still rely a lot on levodopa. And then slowly, and this is from what we learned a lot from DBS, is that we cannot start giving the brain a lot of electricity. People have a lot of problems when we do that. So that's why we need to go slowly increasing the amount of stimulation and kind of like tailoring to what are the needs of the person. So you made it, most people take what you said, 6 months for them to feel that the levodopa is kind of like giving them benefit. And after those 6 months, you mentioned that we do longer visits. People don't need to come as frequently, right?
Right. Yeah. It was, my last visit was in May, and I'm not going back till November. So that's the longest period I'm going to have.
Yeah.
So I feel like I've graduated at one level.
You certainly have.
So yeah, so it's a quality of life issue. It's not a cure, but gosh darn it, we need a cure. So let's all, I guess my final word would be donate your brain. If you haven't done that yet, signed up for that, at least you can do that. And as Dr. Perlman always says, he won't take it until you're ready to give it to him. So
yeah, that's the head of the movement disorder section. So I think Candace is talking about a program that we have here at WSU of brain donation. So we do mention that to people with Parkinson's disease, and if they want to donate their brains, we've done a lot of studies on brains of people that have kindly donated their brains. And you're right, we don't take the brain before you're ready to donate. WSU is one of the centers in the US, but there are multiple other centers that do have a brain donation program. And I think it can be key for us to understand this disease better. So people who are interested should definitely mention to their provider, their neurologist, if they know.
I did have PD generation done, the Parkinson's Foundation gene study, and I found out that I can't blame my mother, father, or my children can't blame me if they get Parkinson's. I don't have any of the markers, but other than that, I would say people are finding that DBS, I mean, given the baby boomers, I think we're really making an impact. The DBS can be done sooner rather than later. Now that's me talking, Dr. Alfradique, you can disagree with me, but I think, but again, you will know, personally, you will know when you're tired of the symptoms that you're having and you think maybe that they will be reduced with, and quality of life will be better with the surgery, then you personally have to decide to go forward with it. Obviously, it's not something that you should do for somebody else.
Yeah, I think it goes back to what I mentioned before. It's like if you feel that there are symptoms of your Parkinson's that are not well addressed by the medication, it is worthwhile to consider whether DBS can help them. So it's important. You don't need to go for an evaluation for DBS already set on having the surgery, because it will be the decision of the specialist that is evaluating, but at least gives you an insight of what DBS could do for specific cases and whether it could help or not. So I think it's always important to keep in the back of the mind DBS as a potential add-on treatment for the Parkinson's. Absolutely.
Great. Thank you. Thank you so much, Dr. Alfradique and Candace. That was a fantastic conversation full of great information. We would now like to open it up to our audience to ask questions. Please feel free to continue submitting your questions using the chat icon below or by selecting the raise hand feature. We are going to stop recording right now.